us today for this live webinar from Medscape titled Saving Hearts, talking about the early intervention for sudden cardiac arrest prevention. This is George Chahoud. I'm a heart failure cardiologist and the regional director for the heart failure clinical program with SSM Health in St. Louis, Missouri. And I have with me as well Dr. Gurpreet Sodhi, advanced heart failure and transplant cardiologist in Sutter Health in Sacramento, California. This is what we're going to try to cover today. In this program, we will be discussing a patient case of heart failure with early initiation of guideline-directed medical therapy. Then we'll touch base on the residual risk in the early month of guideline-directed medical therapy and the role of GDMT titration. And then we'll end by talking about the role of the WCDs in mitigating early risk for sudden cardiac death. So this is a patient of ours that we've seen in our practice. She's a 35-year-old woman with no prior medical history apart from hypertension, morbid obesity, and iron deficiency, who presented with acute decompensated heart failure, progressive shortness of breath and orthopnea with increased weight and lower extremity edema. Symptoms started about 3 weeks prior to presentation. On her EKG, we've seen only sinus tachycardia with a narrow QRS complex, no STT changes. She has an echocardiogram done down in the ER, which showed markedly dilated left ventricle with severely reduced LV systolic function with an ejection fraction of 25 to 30%. We started her on IV diuresis with furosemide. Then she was taken to the cardiac cath lab for right and left heart catheterization, which showed no obstructive coronary disease, but confirmed severely reduced LV function with an EF of 30%. During her hospital admission, we made the plan as per all our protocols to initiate all 4 pillars of GDMT before discharge. So she got started on evidence-based beta blockers with metoprolol succinate, 25 milligram twice a day, along with ARNI with sacubitril valsartan, 26 milligram twice a day. And we added dapagliflozin at 10 milligram and spironolactone, 25 milligram daily, along with that before hospital discharge. And upon discharge, she was scheduled to follow with us in the heart failure disease management clinic within 1 week for the purpose of GDMT up titration. Unfortunately, 3 weeks later, after she's been to the clinic and we've been progressively increasing her GDMT, she presented back to the ER with the symptoms of palpitations. And she said, maybe the device went off because in all our patients, we actually discharge them with a life vest for the protection from sudden cardiac death early on after hospitalization. And that was not any different in her case. But when she presented to the ED, she did report that she had a fluttering in her chest, lost her vision, and she may have blacked out. So presentation EKG in the ER with just sinus tag, but review of the strips from her WCD was consistent initially with a wide complex tachycardia, probably torsade, which degenerated into VFib. She got shocked out of it and back to sinus tachycardia at the time. So this is just to highlight the fact that our patients with heart failure with reduced ejection fraction, whether it's ischemic or non-ischemic, they run the risk of sudden cardiac death. And we have to recognize one fact, which is as important as it is to initiate guideline-directed medical therapy, which has a role on the long run, but also we have to be mindful of the risk of sudden cardiac death after initiation of guideline-directed medical therapy. So, Dr. Sodhi, I'm going to turn it to you here just to kind of guide us through the current guideline-directed medical therapy and the comprehensive approach, and how is your approach to dealing with those patients?
Yeah, no, that's a great case there that you depicted there, and that was a good save on a non-ischemic, very young patient who almost had an SCD and had a cardiac arrest, and fortunately, the life vest saved her. But I think the approach to GDMT, guideline-directed medical therapy, has some advantages. As we know that it helps with quality of life, it helps with reduction of heart failure hospitalizations and also overall total mortality. But one of the things that we, as you mentioned, is that we need to always remember SCD risk. And I think here are some data points that I think the audience should to kind of take home. With the ARNIs, there is a 20% relative risk reduction with ventricular arrhythmias and ICD shocks. And similarly with the MRAs and the RAILS trial and FASE trial, which are now almost 2 decades ago, there was a 23% reduction as well. And similarly, SGLT2 inhibitors with Farxiga and Jardiance, there's a 21% reduction with ventricular arrhythmias and sudden cardiac death, and that's great. But one of the things that we'll take home out of this is the risk reduction is not 100%. There is still a residual relative risk with ventricular arrhythmias and ICDs, even though that these GDMT is fantastic. So I think you were going to talk about a little bit about the mortality with Paradigm and DAPA-HF trial.
So yeah, just to kind of follow up on your point, as you mentioned, GDMT is quite important and it is required prior to managing the long-term arrhythmic risk. We all know the role of ICDs in primary prevention as well as in secondary prevention for sudden cardiac death. But we should recognize as well, as you mentioned, that guideline-directed medical therapy has been shown to reduce mortality as well as hospitalization, and not only total mortality, but also sudden cardiac death risk, as you alluded to with the data from the Paradigm HF and DAPA-HF, which showed a significant reduction in the risk of sudden cardiac death. But one point that we have to highlight as well is the time frame it takes between initiation of guideline-directed medical therapy and that mortality reduction, because most of the studies that we have so far show that it takes at the minimum about 3 to 6 months for that risk reduction in sudden cardiac death to materialize, which means we have to recognize that those patients right out of the bed after diagnosis, they have the highest risk of sudden cardiac death. And as we initiate and up-titrate our guideline-directed medical therapy with the hope that it will change the trajectory and the natural history on the long run, but we have to be mindful that their highest risk is actually in the first 30 to 90 days, like what we've seen in this case presentation, where the patient was saved with the use of a WCD. Because one thing that we have to all realize, and I'm going to turn it to you, is what's the role of ICD in those patient populations? And should we start putting ICDs right after the diagnosis, or should we observe that ICD waiting period as we were taught by the clinical trials and the guidelines recommendations?
Yeah, that's a great question. But I'm going to piggyback one more point to what you said on the previous slide, is that, those data points that you mentioned, those are clinical trial. And these were rigorous trials where you were able to get to target doses based on a protocol. In reality, in real world practice, we have data that that a lot of patients are not even on the GDMT, and not only that, we're not very, very aggressive to get to the highest targeted doses. So there is probably a more delay with the benefit of SCD risk reduction, more than 9 months or so. Now, you made a good point. These are the guidelines based on for almost like a clear decade now, at least. EF less than 35%. If you had an MI without revascularization, you have to wait for 40 days before implementing an ICD. And then for the other categories, you have to wait for 90 days, non-ischemic and MIs with revascularization. But as you pointed out, the highest risk of SCD from data for the last 3 decades is actually within the first 30 days. So you're putting these patients at risk, and it's a conundrum, right? So, do you give a defibrillator early on or not? And you're going to show this in the next slide, some of the data points on that. And we did study that in the early 2000s with 2 pivotal trials. But this is the guidelines, and this is what we have to abide by. So there is this kind of critical period, and I think this is an important point to make. So what are we going to do with these patients who need that benefit from a WCD? We may be able to offer WCDs as a bridge towards reevaluating whether they're a candidate for implantable defibrillators.
And that's exactly right. And this is basically what the trials has showed us, is that the early period post-MI in the IRIS and the Dynamite study showed that the use of ICDs that early within the first 30 to 40 days did not reduce total mortality, even though it did reduce the risk of sudden cardiac death. So there is something to be said about the reason to delay ICD implantation is, number one, in those early post-MI patients, because the negative trials that we've had showed us that there is no indication to initiate ICD therapy in those patients early on. But at the same time, there is a because mainly there is a competing risk of sudden cardiac death early on, more than arrhythmic death, which is highest in the first 3 months post-diagnosis of heart failure or acute MI. And at the same time, we do have some expectation that with the robust GDMT, initiation and up titration to the maximally tolerated dose, or the dose that has been shown to be beneficial in clinical trials, is important, but it takes about 3 months. So we would expect some degree of reverse remodeling, which on average takes about 8 weeks to 12 weeks before we can reassess their LV function to see if they are still candidate for device therapy, which basically gives us that window, which we call it the ICD waiting period, where we are doing our best to revascularize and at the same time try to initiate and up-titrate GDMT. And maybe that's the time frame where the patients are at the highest risk and they need to be protected. So I'm going to piggyback on you and see what's your approach for those patients. Do you have any difference between ischemic versus non-ischemic? Do you use WCDs in all patients for primary prevention of sudden cardiac death? How do you do it in your practice?
Yeah, great question. So I think we made a few excellent points here. Number one, we're not protecting, based on the guidelines, these patients at a critical period in the first 30 to 60 days. Number two, we know that this risk is highest within the 30, 60 days. Number three, what we also did state is that it takes a while for the GDMT to take action and remodel the heart and kind of help reduce SCD. So you're kind of in this conundrum, and so you have a risk, but for the audience, it's, what is the acceptable risk for SCD? And then that kind of brings the point, the role of a WCD. And I think, my opinion is that it's sort of underutilized, it's under recognized, and it's a forgotten tool for our patients. So my approach for WCD is that, you want to offer WCDs to all patients because, you want to try to reduce the risk to 100%, to protect these patients. Now, which patients ought to be covered, with a WCD, that data has not been published or studied. But however, if you offer a WCD amongst all patients, at least you can protect the patient 100% from a SCD event, which, as we just learned, a GDMT doesn't do 100%.
I totally agree with you. And this is part of the problem, is that we still depend on the ejection fraction as a surrogate marker for the risk of sudden cardiac death. But it's not all or none phenomenon, because some patients with reduced EF may not get any sudden cardiac death event. But at the same time, there we should be looking for other markers. But for the lack of a better word, till we get more data with the use of cardiac MR, the role of LGE in identifying which patients at the higher risk, using genetic testing as well that we do in our practice to try to identify more pathogenic gene mutations that may put patients at a higher risk. We're still using the crude measure of ejection fraction. So we kind of do the same in our practice as well, is we do it as a blanket statement that all patients with heart failure with reduced ejection fraction will need to be protected. Granted that the risk, we're talking about 1 to 3%. But any life matters. And since we don't have a way to discriminate who's going to be at the high risk, we know that the patient with an EF less than 20% are definitely high risk. Patient with non-sustained VT that we've seen on tele may be at a higher risk. Other markers may give us at least some insights, but some of these markers, we don't have it right out of the bed. So I would feel more comfortable protecting those patients till we have a robust data to say, well, not all patients need that vest, because we put on about 50 patients for one, they get shocked out of a fatal event. So we use it in our practice as a bridge to decision. So we use it early on for the purpose of protection from sudden cardiac death, as we initiate GDMT and up-titrate to the maximally tolerated dose, and as we revascularize. And at the same time, we use it to kind of protect them from sudden cardiac death risk, with the hope that in 90 days on average, that we reassess their LV function to decide if they are candidate for long-term implantable device therapy. Now, what we did not talk about is what are the cons of using a WCD, which a lot of times it's an uncomfortable device. There is potential risk of inappropriate shocks, which is usually less than 0.5%. So we have to make sure that the patients are fitted well and the patients understand the risk and the benefit, the pros and cons, and that will require a heart team approach to discuss those with patients in general. And that's how we do it in our practice overall. I think from there, we're going to try to open it for any questions from the audience, unless you have anything else to add, Dr. Sodhi.
Yeah, no, I think one last point I was going to make was that, it's a wearable device. It's a temporary device. It reminds the patient that they ought to be compliant with GDMT, which, as we know, takes time. So it also is a motivation for patients to be compliant with their medical therapy and maybe potentially avoid a permanent defibrillator, which also has long-term implications as well. Looks like we have a couple questions. There's one question here that says, which patients would not be candidates for WCD? I don't know if you want to take a stab at it first, and then I can follow you.
Sure. I mean, usually what we look at the patient as a whole, if the patient is frail, older patients, demented, not able to operate the device, this would not be somebody that I'll offer it to. Patient with advanced Parkinson's, patients with significant rheumatoid arthritis, they cannot really abort a shock. Those will be the patients that I would be careful not to offer a device as well.
Yeah, I think also the obvious statement is patients who are just flat out non-compliant, not interested, indifferent. You don't want to be offering therapies that where they're not going to be interested in as well. Well, I think we're at the end here, right?
I believe so.
Well, we want to thank you for participating in this activity. Thank you, Dr. Chu. This was a lot of fun, and we appreciate the audience for coming in, and it was a wonderful discussion.
Thank you, Dr. Sodhi. Thank you all for joining us here today.
Thank you, Dr. Chu. Thank you, everyone. Have a good day.